Muted. All right. I'm Matthew Denver, the Chief Medical Director for the Helen DeVos Children's Hospital. And I want to welcome you to the Helen DeVos Children's Hospital and Michigan State University Pediatric Cafe. Today we have the pleasure of having Stephanie Rashewsky. She's a pediatric dentist here in town. She's born and raised in Grand Rapids. Did her residency, or I'm sorry, her training at Harvard Dental School. She did a residency in dental anesthesia at Stony Brook University and Medical Center in New York. And she did a pediatric residency at Children's Hospital of Philadelphia and University of Pennsylvania. Currently practices here in town at Norman Family and Ada Pediatric Dentistry. I also want to introduce, and I have to apologize if I get the last name a little bit wrong, but Emily Van Hoekelen, who's an oral maxillofacial surgeon here in town and is here to help us answer any questions once we're done with the conversation. So with that, we'll get started.
So the topic today is pediatric dental traumatology, and I thought it would be really interesting to go through some cases. So let's just get started and not delay time. This is a child, a 4-year-old child. Her name is Sarah. She was playing with her siblings, and she fell off her tricycle and bumped her tooth. As you can see, there are two clinical photos, and on both photos, you can see that one of the teeth looks like it's slightly displaced. In this case, it's towards the palate. The first thing when you see a dental trauma in your office, I would recommend that you look at whether or not the teeth are baby teeth or primary teeth or permanent teeth, adult teeth, because the treatment is very different. So this tooth trauma is an example of a primary tooth luxation injury, and the hint should be the child's age. She was 4 years old. Also, the size of the tooth could be an indicator. In this case, you can see that there's rupture of the periodontal ligament, so the ligament that surrounds the tooth. You actually have a fracture through the bone, and you can have possible tooth damage to that permanent tooth bud, which is right here. There are two types of luxation injuries mainly. One is where it's retruded, and the tooth crown will be pushed back towards the palate, or you can have a protrusion injury where the crown is going out towards the face, which means then the root would be pushed towards that adult tooth bud. In tooth traumas, primary tooth luxation injuries, this is relatively, I would say, a good injury for a baby tooth because most of the time the tooth will reposition on its own. So with the tongue pressure, the tooth will go back into that better position. What you need to tell the parents is that the child should have soft food for 10 to 14 days. You also, if the child has any habits like thumb sucking or a pacifier habit, you want them to avoid that. You don't want any additional forces on the traumatized tooth. Good healing is critically dependent on oral hygiene. So you definitely need the parents to brush, even if it's uncomfortable for the child. Often I will recommend that the parents use 0.12% chlorhexidine, also known as Paradex, and to apply it with a cotton swab or a gauze or even a toothbrush to the affected gum tissue, and that's just because you want to get rid of all the microbes so that the tooth can have the best chance of healing. A couple things that you need to advise parents is about the possible damages that can occur. So pulpal damage can occur, and that would be damage to the nerve. This can be evidenced by a little bump on the gum, a pimple, also known as a parulus in the gum. You could have color changes. Various different colors can occur, ranging from yellow to gray to brown to purple, and they do have different indications. The goal, though, is to really minimize complications to those permanent developing teeth. When a child is less than the age of 4 with a tooth trauma, you can have the most damage to the permanent tooth, because at about age 4, the crown completes on those permanent teeth. An important thing to remember is that primary tooth luxation injuries is the most common injury in primary dentition. So if you do see a primary tooth injury, this is very often going to be the one that you'll see. Case number 2 is a little 3-year-old boy. His name is John. He was jumping on the bed and he fell and hit his mouth on a bedpost. So in this case, again, look at the teeth, determine if they're primary or permanent teeth. They are primary teeth. The patient is 3 years old. And you can see that one of the teeth is at a much higher position into the gums. This is an intrusion injury. So an intrusion injury is when you displacement of the tooth into the alveolar bone. When you see this child in your office, the tooth will actually not be mobile because it will have been forced with such a force that it's stuck in that area. The injury is often accompanied by a break of the fracture of the alveolar socket, and you very frequently will have damage to the permanent tooth germ. So in this case, that primary tooth gets pushed up and actually will hit that permanent tooth. Right here, you can see how close that is in proximity. The treatment for this is usually just to allow the tooth to re-erupt. It's actually one of the better injuries as well. So 90% of the time, the tooth will re-erupt. It will take several months. Typically, you get about 1 millimeter of re-eruption per month. So in 2 to 6 months, you should see full eruption of that tooth. Similar to the previous injury, you want the patient to have a soft diet and excellent oral hygiene. You also need to advise the parents about the possible complications. So I tell parents to watch for signs and symptoms of infection, a pimple or bubble in the gum, color change, pain, fever. If any of those things occur, you definitely need them to follow up with a dentist. And with all tooth trauma injuries, I would recommend that the child follow up with a pediatric dentist as soon as realistically as possible. The key point for these are that intrusion injuries typically do re-erupt. So this is case number 3, and now we're moving on to permanent tooth trauma. So this is a 9-year-old girl. Her name is Molly. She ran into the pull-up bar in the playground and knocked out 2 teeth. You can see that the 2 incisors, mandibular incisors, were avulsed. It's number teeth, adult teeth have numbers, so it would be number 23 and 24 were avulsed, and there's a bloody mess in there. You can also tell that these are permanent teeth. So one of the ways is the size, but also you can see a little bit of a bump. Those are called mamelons. When teeth first erupt into the mouth, they do have mamelons at that incisal edge. Now, this tooth trauma is a true emergency. This is where timing makes a difference, and you need to get that tooth back in as soon as possible. If you happen to see this in your office, or if you're at a soccer practice and see it on the soccer field, put the tooth back in. So the tooth in this injury will be completely out of the socket. You want to make sure that it's a permanent tooth. Only replant permanent teeth. Do not replant primary teeth. And the reason is, when you replant primary teeth, you will actually possibly damage that permanent tooth bud, which is there. So similar to an intrusion injury where it gets pushed up, you don't want to cause damage to the permanent tooth that's forming. If you do find this tooth on the ground, you want to pick it up by the crown and avoid touching the root. And that's because the root has all sorts of really good cells in there and a periodontal ligament, and you want to keep that intact as you can. If it is dirty, wash it briefly. Now, if for some reason you can't replant the tooth or the parent can't replant the tooth, you want to put it in a good medium. So number 1 would be Hank's balanced salt solution, which a lot of people don't have lying around. Number 2 is milk. So if you can't replant it, place it in milk. Now, the success of this tooth will be dependent on the status of the root of the tooth. So teeth that first erupt have what we call open apices, where the root will have a lot of regenerative potential. If you have a child who's older, let's say 16, 17, 18, the apex will be closed, and that's more concerning. In terms of treating this, this will need to be seen by a dentist or someone who's skilled at putting on a splint. The tooth needs to be splinted for about 1 to 2 weeks. It's important that the child is also given antibiotics. Ideally, if the child is above the age of 8 to 9 years old, use doxycycline. The reason you don't want to use doxy in young children is because it can cause tooth discoloration. But the older the child is, you won't have a problem with that. This child will also need a tetanus booster if they aren't up to date on their vaccinations. Obviously, refer to the dentist. In terms of post-treatment instructions, you want the child to avoid contact sports because you don't want them to re-traumatize the area. You want a soft diet for 2 weeks, excellent oral hygiene as before. Chlorhexidine mouth rinses twice a day is going to be critical, and they're going to have a good relationship with their dentist for follow-up, including splint removal, radiographs at regular intervals, possibly root canal treatment depending on the status of the apex of the tooth. The key point for this injury is that permanent tooth avulsions are a true emergency. Now we have case number 4. Again, this is a permanent tooth trauma. You can see those little mamelons on the tooth. So this is going to be a 9-year-old little boy who was playing baseball. He tried to catch a pop-up fly, and the ball hit his teeth. And this is what we call crown fractures. I actually saw this tooth trauma in the office yesterday. If you look at this radiograph, you can see that the apex is wide open. So these are newly erupted teeth. By newly erupted, we would say within the last 2 years, most likely. So in permanent tooth crown fractures, you want to first find out if it's a complicated fracture or an uncomplicated fracture. This used to be known as the Ellis classification for tooth trauma. I'm not sure if you all remember, but there was an Ellis class 1, Ellis class 2, Ellis class 3. Now it's been renamed to be more descriptive, whether it's a complicated or an uncomplicated fracture. And that distinction is whether the pulp is exposed. So in this case, it's an uncomplicated fracture through the enamel, that outer part, and then the dentin. But the nerve, the pulp, was not exposed, so you would not see red or bleeding. The tooth can be very sensitive. It's important when you send the child to the dentist that the dentist will take radiographs from multiple angles, and that's to verify whether or not there's been a root fracture, because that would change the treatment. For sensitivity, the dentist, or if you could place glass ionomer, which will help relieve that sensitivity, and then you want to restore with composite, which is white filling material. The tooth is going to have to be monitored for pulpal necrosis, so you want to make sure that that nerve stays healthy. The key point in this injury is to determine if the fracture is a complicated or an uncomplicated tooth fracture. In terms of dental trauma in kids, it's very common. 30% of preschoolers suffer from dental injuries. I saw 2 dental traumas in preschoolers yesterday, and that number actually goes up to about 50% by the teenage years. Primary tooth trauma is most common in 2 to 3-year-olds. Sports-related injuries are most common in 7 to 11-year-olds, and it often involves the maxillary central incisors. It's going to be more common in boys, more common in children with malocclusions, where their front central incisors jut out further. Also more common in children with special needs and seizure disorders. The important thing to remember is many oral and dental injuries are preventable, especially those sports-related ones, if the child wears a mouth guard. So if you can encourage all of your kids playing contact sports, baseball, football, basketball, soccer, hockey, get them in mouth guards. I know that for hockey and football, it's required. Baseball and basketball is not, and they actually should be wearing mouth guards. If you have a tooth trauma, again, we would love you to use Save a Tooth, because that's Hank's Bound Salt Solution. That's most ideal in terms of a medium for storage. But if you don't have that, milk is the second best thing. Mouth guards are great because they absorb and distribute the forces. It also can decrease the incidence of concussion. It protects the soft tissue, lips, cheek, gums, things like that. A lot of kids right now are loving the Under Armour mouth guards, but any mouth guards that they would wear, I'd be happy with. A resource that I think is absolutely wonderful for all of you is called the dentaltraumaguide.org. If you just go www.dentaltraumaguide.org, you will see this wonderful website. It will let you select whether it's a primary tooth or a permanent tooth, and then it will go through the various tooth injuries. And it actually goes through the etiology, the description, the treatment. It's a wonderful resource. It's good for also educating the parents. The various dental trauma categories, which are discussed in the Dental Trauma Guide, include concussion, which is a minor bump of the tooth, a subluxation injury, where there's mobility, but there's not going to be displacement of the tooth, the lateral luxation, which we discussed, extrusion injuries, or when the tooth is pushed a little bit out of the socket, but not as far as an avulsion, intrusion, which is the opposite, where it's intruded into the gums, an avulsion, which we also discussed. Then there are various fractures. There's fractures of the enamel and dentin, enamel-dentin pulp, which is that complicated tooth fracture. And you can also have root fractures, alveolar fractures, and jaw fractures. Here are some various injuries that I happened to see when I was in my training. These are all in primary teeth. You have an alveolar fracture over here. This is a pulp, so this is a fracture where there's pulp exposure. This is a severe crown fracture as well. This is a luxation injury. Some of the fractures can also be rather combined in terms of the injuries. This one actually, I think, has a luxation component and also slight extrusion component. And here is an extrusion injury. And then these are permanent tooth traumas. So these are avulsions here. This is a permanent tooth intrusion. This is a severe intrusion. This one actually is an adult tooth, so you need to reposition that. Whereas in the child, you could allow for re-eruption. When you have an intrusion to this degree, considered to be more than 7 millimeters, you do need to reposition. This injury doesn't look that severe. It's a slight extrusion. The problem is the child's in traumatic occlusion, meaning when they bite down, they're re-traumatizing that tooth continuously. So that one does need to be repositioned. Here's an extrusion injury. This is a severe alveolar fracture where the teeth are completely displaced. So you're seeing the lingual or the palatal side of the teeth. And then this is what the teeth looked like when that whole segment was repositioned and the fracture was reduced. And that's all.